Welcome to Healthbeat, where we take the pulse of South Africa's healthcare system. I'm Mia Malan. South Africa is facing one of its biggest tests since 1994. How to make healthcare something that everyone can afford when they need it. After 30 years of government promises, in May 2024, President Cyril Ramaphosa signed the National Health Insurance Bill into law. One fund, public and private money pooled together, equal access to healthcare. But less than 2 years later, there are court cases from all sides. Is our healthcare system tearing itself apart?
The NHI Act isn't just being challenged for what it says, but also for the way it was signed into law. Medical aid companies, doctors' organizations, private hospital groups, big business, and even health activists are asking the same question. Does it go against the Constitution? Can the country afford it? And can our government run a R1 trillion fund without the money being stolen?
The litigation is an inevitable result of the way that the lawmaking process has unfolded. And that's not because there hasn't been consultation. There were years of consultation. More consultation really on the NHI bill than on many other pieces of legislation, in that there were provincial roadshows, there were multiple opportunities to give comment in Parliament.
By establishing a national health insurance fund. Written submissions must be directed to Ms.
The problem, though, was that while there was all this consultation happening, very little of what was proposed in the consultation actually got considered, it seems. Of course, there's no obligation to take on the suggestions of everyone. That would make it completely unwieldy to try and make law. But so many of the concerns that were raised by many parties, many stakeholders across the board, just didn't seem to be taken into account in the finalized bill that then became an act.
Among the concerned parties, the Board of Healthcare Funders, which represents medical schemes. Katlego Muturi is the MD.
The thrust of our argument is to harmonize the Act with the Constitution. We need to find the correct application of provision of essential healthcare services to those who need it, when they need it, where they are residing. When we examined the Act, we found what we regard to be many inconsistencies between the intention and what the Act says.
Last year, the High Court said the president's actions could be challenged.
Firstly, decisions made by government should be reasoned. It's a key part of a constitutional democracy that we've gone from an apartheid era of decisions being made on high without any need to justify those decisions to the public who they affect, to a system where those in charge can't just make decisions because they feel like it.
The government appealed to the Constitutional Court and also asked for all the cases to be merged so the health department can answer them in one go.
And so if there is a consolidation, then there will need to be a huge timetable about who needs to file what and when. That's all pending what happens in the Constitutional Court. Now, the applicants in all of these cases have opposed this stay and consolidation because they say it impacts their own access to court.
The Western Cape government believes public participation processes were flawed. Ramaphosa has now written to the opponents, promising not to bring any part of the Act into operation until the ConCourt has ruled on two things: whether Parliament followed a fair public process and whether the president's decision-making powers can be reviewed. The ConCourt case is set for early May. Its ruling will shape what happens to the other cases. Elzebie Klink advises the South African Medical Association, which represents doctors in public and private hospitals. Sama wants the courts to decide whether the Act could make it harder for doctors to care for patients and weaken parts of the health system rather than strengthen them.
SAMA is not part of the stay and consolidation because it wants to preserve its resources on the substance. But every side thing that happens costs a lot of money to respond to. And it delays everything, and increases uncertainty. And we're not getting the answers and the guidance that we need as to what does access to healthcare mean? Does it mean NHI? Does universal coverage mean NHI?
While lawyers argue and the bills pile up, the health system doesn't pause. Attention that should be going into fixing clinics and hospitals is being pulled in all directions. And financial scandals still haunt the health system, like the billions looted at Tembisa Hospital. Private healthcare isn't innocent either.
You get full cover in hospital for specialists with whom we have a payment arrangement. Other healthcare professionals.
Medical schemes push up costs and keep care behind a paywall, says Lutando Vilagazi from Open Secrets, which exposes private sector economic crimes.
These different healthcare providers that have taken the NHI to the courts and questioned its validity have ample amounts of money to be able to make sure that it never sees the light of day purely by holding it up in the court processes. Because if the NHI is implemented in its entirety, perfectly or imperfectly, if it was properly implemented, it would essentially render the need for a private healthcare system unnecessary and moot. Most of the time, people turn to private healthcare because they can't find those services or access them through the public sector. If that need was met, there's no need for private medical aid. So that's the ideological issue, essentially. It's about the fate of private healthcare.
Professor Susan Cleary from UCT School of Public Health has been working on the economics and best case options for a health system. Susan, thanks very much for joining us today. What's wrong with the current public health system? Why do we need to change it?
The potential of the current public system is amazing. And many of us have questions about why we are moving from a system that is one financing model called a National Health Service model to another financing model, which is called a National Health Insurance model. And there are actual benefits to the current model that we won't get under the NHI model.
So what is the difference between our current model that we have and what the NHI proposes?
The current model is a model where I think the main thing to think about is that the employees that provide services in the facilities are salaried employees of government. Whereas under the NHI model, it will be possible for government to contract for services from independent entities, including private GP practices, including private hospitals. So I think that there are potentially big benefits to an NHI model for private GPs and potentially for private hospital groups. There are potential disadvantages. At the moment, National Treasury collects the funding, that's not going to change, and then sends it to the provinces who then send it to the provincial departments of health. So you have, in effect, 9 pots of money. Under the NHI, there will be the single pot of money held in the NHI fund. And that leads to concerns about what will happen if that money isn't managed well, because there will be no alternative.
So if you look at the NHI Act, Susan, are there any protections built in against corruption?
As it stands at the moment, the Minister of Health has a lot of authority to appoint the colleagues that choose the board, the chair of the board, and the CEO of the fund. There's also a sort of scope for the minister to appoint people to the appeals tribunal. And so I think that this is something that concerns many people because there aren't sufficient checks and balances. Obviously, we have to have politicians involved in these decisions. But what people are asking is if Parliament could play a bigger role in approving certain positions.
Now, a lot of the public debate around the NHI comes down to affordability. How should South Africans think about what is and isn't affordable when it comes to giving everyone access to healthcare?
If we are to say that the NHI, in effect, is going to be similar to our current public sector, offering services to the value of about 5,000 Rand per capita per annum, then extending that from about 80% of the population to 100% of the population is probably broadly affordable. But if we are planning for the NHI to be more similar to what we see in the private sector, offering care of about 15,000 Rand per capita per annum, then we're looking at close to 30% of GDP being spent on healthcare. And that is simply not an amount of money that we should be planning to spend on healthcare. But in terms of actually defining what the cost will be and whether it's affordable, we cannot know the answer to that until we have a sense of the exact services that the NHI is going to offer. And you'll see that that comes up quite a lot in the various court challenges, is that at this stage, we don't have a sense of what's called the benefits, the services, the interventions, the procedures, the surgeries, etc., that are going to be offered. That process of deciding on the services is a big deal.
Aren't there things that we must fix first before we can roll out an NHI? And what are the most urgent issues?
So I think that it's fair to say that there are pockets of the current public sector that are offering an excellent service, particularly with the amount of money that they've got. Recently, they came in the top 30 hospitals globally. No private hospital in South Africa came onto that ranking system. And there are excellent providers in the public sector, but there are, of course, a lot of other not so good hospitals, facilities, providers, and there is the issue of poor management, poor governance.
Do we have other issues? Like, for instance, we only have an electronic patient system in the Western Cape. We don't have one in the rest of the country.
Yeah, so I think that the electronic information system is a win-win. I think no matter what we do going forward, getting that right will be a game changer. And getting that right for the private sector as well will be a game changer, because at this stage, that definitely does not exist in the private sector. In the public sector, I think that we've seen a big increase in quality of care in the Western Cape since we've had electronic information systems. So that needs to be done, and that does not need an NHI. That should have been done last decade.
And when it comes to funding, is it realistic to say that the NHI can be funded through public taxes, through payroll taxes, in a country where there's a 30% unemployment rate?
To absorb 100% of the population into a single unitary health system with the current level of economic growth, and also make that system better than the current public sector, is very ambitious.
Susan, we've spoken about the public sector, but is the private health sector in South Africa equipped to roll out an NHI?
The concern is that you've got your 20% of the population that are dependent on the private sector. It would not be good if those people ended up dependent on the public sector with the current level of budget that is available in the public sector. That would lead to overall worsening of care for the entire population.
After the break, the man driving the NHI, Health Minister Aaron Motsoaledi. You with Healthbeat. For Health Minister Aaron Motsoaledi, the legacy he wants to leave behind is the NHI.
This is our dream, at least my dream.
But with court cases piling up, Motsoaledi's dream is on hold. Many disagree with his approach to universal healthcare, believing there are alternative paths. Some people would argue that it might be even better to prevent the court cases and reach compromises on the act outside of court.
There's nothing wrong in talking. The question is what are you discussing and what is the ultimate aim? But talking is very important. This country has always believed in talking. BUSA, the business unit South Africa, met with the president and they told him that they've got better alternatives. The main one is that because people who are on medical aids have remained static at about 9 million, they will increase it to 27 million. That means 27 million South Africans on medical aids.
And with medical aids, the NHI Act says they cannot exist in their current form in the sense that they cannot provide the same services as the NHI. And that has been such a controversial clause.
There are lots of things that medical aid refuse to cover, and the government healthcare system must cover. It's happening like that. You are aware that people who are doing that are 14% of the population who are on medical aids. 86% can't. This double dipping. I can do it. I can go to a public hospital. If I'm not happy, take medical aid, go to a private hospital. For the same condition, I can go around consulting for the same condition as many times as I want.
Section 33, that medical aid section in the NHI Act, are you talking to people about possible changes to that section?
We are not talking about possible changes to anything. We are talking about health reform in the country. Because number one, healthcare is very expensive in the private sector. I'm sure everybody accepts that. Number two, the private sector has got all the resources and is heavily subsidized by the state, but it covers only 14% of the population.
So what we need to improve healthcare by using the NHI, to be able to fund it, is in a large part the medical aid premiums and subsidies.
We want to pool the funds into one big pool, yes, which will cover all South Africans. But yes, Section 49 of the Act clearly says, then the medical aid credits must also be taken away to fund the public funded pool. That will allow people to use both the public and the private sector. And we're saying in that instance, then if you want to keep your medical aid, you can keep it. Nobody will stop you, but it's complementary.
Are you talking to some of the people who are bringing court cases against the NHI Act to look at potential compromises to not have court cases?
Look, Mia, this act, the NHI Act, is not written in stone or in concrete. No act is. All acts get amended because you put them in and you realize it's not serving their purpose. Even the Constitution, there's been many amendments to the Constitution. I am having a meeting with Sama because I did meet them, yes. We discussed about this issue and finally said, no, we need a special day where we spend the whole day talking about it. And we are busy making a date for that meeting. South African Medical Association, they also took us to court. And I said, let's sit down and speak. Because when in that meeting I was with them, I found that we are sharing a lot of things in common.
And if you can reach some sort of compromise on the issues that some of these parties are very concerned with, would you consider that in order to avoid the court cases?
Yeah, but as you agree, you have already said when we started, it's an act of parliament. Obviously, it all depends if parliament wants to change anything.
Absolutely. But we also know that the ANC is the main party in parliament. So if you, as a party, decide you'll vote for certain compromises, then it will be passed.
So you know the state of parliament now. It's no longer like in the 6th parliament where ANC had more than 51% majority. If the act needs 51%, it needs other parties. There have to be an agreement with other parties.
And that will be, within your negotiating power.
Yes, I'll say so. All I'm saying is that no one party can pass anything alone in parliament now.
You're one of the few ministers who've never been accused of corruption. But what has happened is there's been a lot of corruption in provincial health departments while you've been the health minister. Why has that happened?
Thanks for the accolade, Mia. Thanks. And it so happened that I raised this issue in quite a number of fora. The problems are in your provincial government. The first one is HR. We've got many instances where wrong people are put in wrong places. The second is financial management. Once money gets into a provincial department as equitable share, the province can do whatever they want with it. They are audited separately from us. The third is infrastructure management. If a hospital is built and, it can simply fall apart and there's no maintenance and all that. And the last one is procurement. Procurement happens purely in provinces, like it happened in Tembisa, where the corruption happen. If you look at these four things, it means as a minister, you are given responsibility for that which you don't have authority for. And I said, that's where our problem is. Now, in the NHI, we are seeking to change that. And one of the reasons why the Western Cape has gone to court is to challenge that. They are saying you are usurping powers of provinces. And if we don't do anything with those powers and there's corruption, you come and ask me and say, why is there corruption that is happening under your watch? But I've not been given the authority. No minister anywhere in the country appoints MECs.
How will the NHI fund, a central fund, prevent corruption like we saw at Tembisa Hospital?
Once there's corruption, there can't be development. And we said we want a developmental state. But now we're acting in a way that we allow that corruption to take place. If you read the NHI Act very well, you realize the mechanism that they put in place to stop that. For instance, none of the fund is going to be controlled in the manner in which you control budgets now, which means once you have got an NHI fund, you can't say the minister or this MEC or that controls the fund. They don't. They are very far from it. It's controlled by a board, which is chosen not by me only, where members of parliament will participate.
This has been pointed out by the Democratic Alliance.
The second thing, in procurement, it is done by a team of people called a bid adjudication committee. There won't be any chance of skinny jeans and all that being bought. So it's not one person who believes I've got political power or managerial power.
Some of your critics are concerned that the NHI Act gives the Health Minister too much power to hire and fire those boards and committees that you've mentioned.
But I'm not really a power monger.
I don't think your critics are concerned about your choices necessarily. They're concerned about the Health Minister in general. The person who follows you may very well be corrupt.
Same as members of parliament who come in a particular committee may all well be corrupt. So I don't think we should put labels and say if it's done in this way. Let's look at the system, whether the system is foolproof.
But should we not have more protection in the law?
Oh, yes, I agree.
Should the powers of the Health Minister not be less?
No, I agree. If they start feeling that's it, look, Mia, this act, if there is a very strong feeling that, no, this one is not saving people as it should, then it gets amended.
Contracting facilities, private and public facilities, to start providing services. How soon would you like to see that happening?
As soon as possible, Mia, because I'll tell you, we keep on emphasizing that NHI is not going to be an event where we put a date and say, tomorrow is NHI, It's going to be a gradual process. Every country has done that. Every country that has implemented universal health coverage has done exactly that, bit by bit.
By when would you like to see the first benefit package for the NHI released? How long from now?
If it was not for court cases and for challenges in the regulations, I would have liked it to have started by now. Because we can't keep on postponing benefits of people. I would have liked it to have started now.
With the court cases, it might be indefinite.
Yes, it might be indefinite for the court cases. That is true. That's why we are prepared to say, if anybody wants us to sit and talk, let's do so.
So the fastest way to get the NHI is going to be to work around court cases and agree on stuff, right?
In an ideal world, yes. But this is not an ideal world, Mia.
Fixing our health system is urgent, and so is finding common ground. But that needs something that seems to be in short supply: compromise. Can our health system survive for long enough for everyone to find it? Share your thoughts and ideas with us on social media. Goodbye.